Hello, I'm Eden Wells, and I'm the Chief Medical Executive for the Michigan Department of Health and Human Services. I'm here to talk to you today to talk about the lead poisoning prevention program that we have in place here in the state of Michigan. This is a quick tutorial, fairly focused. It's for primary care providers who are considering the need to screen their children, or in fact any adults at risk that may present to their clinics for elevated blood lead levels. What we will cover today is really the issue about why we, even in this 2015, we still care about lead poisoning. We want to identify lead risks and hazards. I'll talk to you a bit about the etymology and the clinical diagnostic issues that occur when we're thinking about lead toxicity. Treatment and guidance will be provided, and resources to support those. Follow-up and retesting guidance is important, and then we will also again complete. There are resources available to primary care providers throughout Michigan, and we'll give you those numbers and websites. So, as a public health practitioner and as a background in clinical medicine, it is absolutely amazing to think that lead poisoning still matters even decades after we've had regulatory laws in effect to control issues of lead. Lead poisoning still now remains the greatest environmental health risk to Michigan children under the age of 6. Nearly 3,000 children between the ages of 0 to 16 were identified as lead poisoned in 2014. That's given in a population in Michigan just around 10 million. Lead neurotoxicity is irreversible. So this is a preventable, 100% preventable toxicity that we could prevent if we are aware and be able to screen our at-risk population. So how are children lead poisoned? I'm going to focus today about the children because they are the most at risk. But over 90% of Michigan cases are from lead paint. Aging housing, particularly housing materials, paint that's been peeling, chipping paint particularly, may be particles that are easily ingested by children. Lead dust and small particulates, even when the paint is not peeling, can be easily inhaled. People are often surprised that actually the action of opening and closing windows that may have the old paint can actually liberate quite a bit of dust and lead chips into the air and onto the floor. The child then, with the typical hand-to-mouth behaviors that children have, will then be more at risk to ingest these and thus are at increased risk for lead exposure. Again, more on how they're poisoned. Paint being the highest risk factor that we are aware of in this state. Chips and dust primarily make up the largest components. But there are other resources. We need to be aware that when we are talking to our families about risks for lead exposure, to think about soil. The lead dust actually around home sites or in other areas when there's been environmental exposures to lead, the lead will remain in the soil for forever, and children who are playing in the soil can thus be exposed. Drinking water may be an issue, particularly in those folks that are not on municipal or city maintenance water and still have lead pipes which may be connected to their home. Caregiver hobbies and occupations, automotive occupations, those people who use soldering, especially around hobbies such as stained glass making, other people who may work in metallurgy, recycling, firearms, particularly those people who work in firearm range areas. For instance, practicing their shooting in a gun range can actually, in an enclosed area, have an impressive amount of lead dust present. Various potteries, particularly glazes that are used, lead actually makes the glaze in a very smooth consistency, and so potters have been at risk to lead. And there have been cases of children that have been inadvertently exposed to the potter's glazing materials and thus have been poisoned. Jewelry and folk remedies, particularly if they come from areas from other countries where people engage in folk remedies or in jewelry that's made of lead that is not typically made now here in the United States. These citizens need to be asked about their use of folk remedies or whether or not they're wearing any jewelry that may contain lead, should they be presenting with symptoms or signs of lead toxicity. Risk factors then for lead poisoning that should always be kept in mind in the primary caregiver here in Michigan. Living in a house built before 1950. Living in a house built before 1978 that has been remodeled in the past year. That remodeling actually lifts and may actually re-energize some of the lead that may have been present prior. Living with a sibling or a playmate with lead poisoning. Clearly, a child who plays with others may actually not have been exposed in the household of the family, but in fact a playmate's household or play area. So these questions really need to be targeted to examine all potential risk factors among not only siblings, but the playmates that the child may be with. Particularly also to remember to think about living with an adult, a caregiver, or a extended family who may be working an occupation that puts them at risk for lead exposure. And this may also be a hobby that may put them at risk. And remember also, it is not uncommon, particularly with our diverse populations that we enjoy here in Michigan, to ask people about the use of any traditional or home remedies that may inadvertently be contaminated with lead. Or, in fact, there are some remedies that are utilized in a number of countries and cultures that may purposely put lead within the remedy. So this really is a source that we need to be cognizant of and to think about when we're caring for our patients. So, who should be tested? All Medicaid patients must be tested at ages 1 and 2 years of age. Children who were not tested between 1 and 2 should be tested at least once between the ages of 3 and 6 years. All children who are living in housing built before 1978 or residing with a caregiver who has employment, a hobby, or remedy-related risk behaviors, those children should be tested. And any child exhibiting any symptoms of lead poisoning. What are those symptoms? The symptomatology is sometimes vague, and in fact, unfortunately, children may not present with classical symptoms, and some may be absolutely asymptomatic. So again, the index of suspicion should be there. And in fact, early on, clinical symptoms may be anemia in a child that's presenting to your clinic. Now, first off, certainly with anemia, you need to be aware to think about that might represent iron deficiency. But be aware that we also need to think about lead, and I'll talk more about that in a second. Anorexia, abdominal pain, constipation. Again, fairly vague symptoms, but this conglomeration of anorexia, anemia, abdominal pain, and constipation should make the physician, particularly in a child that's very young in age, to think about the possibility of lead toxicity. If toxicity symptoms are more prevalent, we're going to see a child who has a change in mentation. In fact, they may present with encephalopathic features that will include confusion, difficulty speaking. There will be ataxia, seizures, and of course, as we progress, coma and death. I should point out that the 3 issues of seizures, coma, and death would represent extremely high blood levels and, of course, are a pediatric emergency. The metabolism of lead is actually quite interesting, and most of the lead that is ingested would be absorbed within the gastrointestinal system. The absorption is similar to that of iron or calcium and carries the same biodynamics. Absorption rates and uptake depend on the age and size of the child and the type of exposure. So there would be some differences between a very high acute exposure versus that of chronic exposures, small amounts over time. So about 65 to 70% of the total body lead is stored in bone in children. This bone half-life can be very long, so this is something we can pick up on x-rays, and this half-life is 10 to 30 years. So once poisoned, the bones are probably going to show signs of lead findings for many years to come. The blood half-life itself is about 1 month. So we should be able to see decreases in blood lead after the child has been removed from the source of exposure or has been treated over a fairly short period of time. But bone lead, in fact, this is a very classic x-ray right here in the lower right-hand corner of your slide. What we're seeing here are lead lines. This is a 2-month-old with a blood lead level of just 10.6. And now 10.6 is elevated, but not highly elevated. So this child's been likely exposed chronically over a period of time. These are the long bones, and then the growth plates. As we can see here, at the distal end of the growth plates, we're seeing a very heavy deposition of lead, which lights up much better on x-rays than the actual bone itself and the calcium. So this is pathognomonic, classic of lead line signs that would make the radiologist and subsequently any provider be highly suspicious of lead exposure toxicity, and this needs to be promptly evaluated. Known effects also, in addition to that of bone, would be the hematopoietic effects and the sine qua non of the child presenting with anemia. Lead interferes with the synthesis of heme. The iron insufficiency, in fact, in a child will actually lead to more lead absorption. So one of the things that we are concerned about is any child who's nutritionally deficient, perhaps for whatever background they may be living in, whatever circumstances they may be in, a child who's actually iron deficient at baseline is going to have an increased risk for higher levels of lead absorption compared to the child who's not anemic. So thus, an iron deficiency anemia would actually be associated with higher lead levels, and we need to think when we're seeing a child with anemia to ensure that we're also not also seeing a child with lead toxicity. Lead also interferes with the synthesis of hemoglobin, and so this iron deficiency state, what the body will do and the red blood cells will do is uptake iron in, uptake the lead if in fact there is no iron there for the red blood cells to take up, and thus what we have are red blood cell effects that are, again, pathognomonic if this is seen under a microscope, and your hematologist is likely going to make note of this, but basophilic stippling, as can be noted with the nice purple spots here on the cytoplasm of the red blood cell here. We've got some very irregular red blood cells. You can see some of the iron deficiency as well within this picture. And you're going to see actually levels of free erythrocyte protoporphyrin. Essentially, you've got defective heme and hemoglobin synthesis, and the association with iron deficiency, again, is a very important issue that the primary caregiver must be aware of. Other known effects on the neurologic system, these are probably the most that, as a public health practitioner and a primary caregiver, that has some of the greatest impacts. And again, because these are often irreversible. Violence and aggressive behavior have been associated in children who have had elevated blood lead levels. This also is associated with learning disorders, attention deficit hypersensitivity or hyperactivity disorder, or ADHD. And one of the findings that has been particularly striking over the last few years and noted by the American Academy of Pediatrics and the CDC is that the IQ, or the intellectual quotient of the child, has been shown to decrease as much as 5 to 8 points with lead levels even as low as 10. And so what we're looking at here is the recent studies also that show that this impact on IQ may actually occur at levels below 10. And so you'll see when we talk about the recommendations for screening how our blood lead level levels that we feel ought to be followed up on are now much lower than 10. Outcomes, again, we've talked about, there's been studies that actually shown that criminal behavior in adulthood may be associated with children who have had elevated blood lead levels in their childhood ages. This can be also associated with juvenile delinquency, elevated school dropout rates, certainly direct behavioral impacts as the child is being exposed to the toxic agent. But clearly this is a issue of extreme importance. Many of these learning disorders, attention deficit disorders and such, have been increasing in incidence over time. Some of these, if they're evaluated, may be related to lead, and we need to be thinking about that if we're having had children at risk for lead exposure. Okay. So the guidance sheet I'd like to show you here, and one that you can actually print off, post on your clinic wall, is important is to think about children who either have not been tested, and then those children that have been tested and what to do when their blood lead levels come back, or their BLLs come back to you from the lab. First off, all children should be screened with risk factors. We've already talked about that. As you can see at the bottom, all Medicaid children, again, at ages of 1 and 2 years of age, and those children who have not been tested for whatever reason should be tested at least once between ages 3 and 6. So, for all of those that are screened, if the blood level or BLL comes back less than 5, it is key at this point, obviously throughout any blood result we're going to be talking with the family and giving them the results. I would think that in any levels that don't require immediate treatment, certainly anticipatory guidance should be given. And this is the type of guidance to give to families so that they know how to minimize in the future any potential risks for lead exposure should they arise. And even though for here the lead levels may be normal under 5, I would still advise that children or families should be aware that their children can still be exposed from soil, playing in the dirt, so they should be knowing to, for instance, remove their shoes when they're coming in the house, to wash their hands. If there are family members working with lead hobbies and such, to not be wearing those clothes into the house. Perhaps they should be wearing a gown or something to protect themselves during their hobby that is not brought into the home. To think about other risks as well, particularly given the age of the house that the family lives in. In that case, however, if you get a blood lead level back, and this is not uncommon in the practices and the colleagues that I work with in Michigan, is not uncommon to get levels between 5 and 14. And in there, again, we want to make sure, in this case, we're going to do a bit more. We do need to do a further investigation with the family, and sometimes we'll do this with a case manager, but we'll want to make sure that an environmental history is taken. Where has that child been potentially exposed, and are there other children in the household or any of the child's playmates that may have also been exposed to the potential lead in the environment? In all cases, consider iron insufficiency. This may be an issue where a child has not been getting adequate nutrition. Again, if this is not the case, we need to make sure that they're getting good calcium and iron supplementation. And if they are not part of a WIC program and need to be, that may be a great way to get them in. Again, that can also be part of your anticipatory guidance. The case management is always made available, and public health departments have the programs in place, along with the state-led exposure prevention program, that can assist primary care providers in getting case management to help get the child or their family the best care they can if there's been an elevated level of blood lead. Now, when the blood lead level gets from 15 to 44, do know that that is much higher, and we have to get a bit more interventions going. So, issues of follow-up and testing are very, very important. If we have a child that has been tested and the blood lead level comes back between 5 and 14, retest again 1 to 3 months just to be sure that that blood lead level is not increasing or staying the same. We want to make sure that whatever that exposure was has been removed and that the blood lead level is coming back down to normal. But if our child comes back with a blood lead level from 15 to 44, that is clearly, we want to be very, very careful that it's getting close to toxic levels. That child needs to be followed closely. The child must have venous sampling done until the levels are less than 15, and this testing must be done monthly. And this should be repeated continually until at least every 1 to 3 months until those levels come down under 5. And again, 5 is now the level which we consider the best. It's not, and we would like to prefer to have everybody have a level of 0, but at least at this point, our 5 is our cutoff for what we consider a acceptable level of blood lead level. Now, if the blood lead level comes back at greater than 44, this is really a time where this is not for a routine follow-up. This child must be treated. This child must be sought out. Family must be brought in. Child must receive care right away. Not only should the blood level results be discussed with the family, but the treatment should be performed in consultation with specialists who are trained in the treatment of lead toxicity. Those here in the state of Michigan are really the experts at the Children's Hospital of Michigan in Detroit. They can provide consultation by phone. If need be, there can be care that can be planned for the child immediately in partnership with you and your clinic. The follow-up subsequently from treatment, after this patient has undergone treatment, will be directed by specialists. This is a very highly skilled type of treatment that's provided, and different levels of chelation are actually required depending upon the lead exposure and what the type of symptoms the child may be experiencing. So chelation for lead toxicity needs to be done by a specialist, and we recommend that you do that in partnership with the Children's Hospital of Michigan. So, more action for the provider. Again, just to summarize, testing all Medicaid children at ages 1 and 2, making sure that if they've not been tested at that age, and this can often happen if they're moving in from out of state or from another country, make sure they're tested at least once between the ages of 3 and 6 years. Follow-up testing is required to ensure lead levels decrease, and they should decrease under the level of 5. Offer any education and anticipatory guidance, some of the examples I gave, to parents on any safe cleaning practices and healthy eating behaviors. Again, if your children are eligible for WIC, that's an incredibly great program to make sure they're getting adequate nutrition. We do want to make sure that any potential sources or causes of iron deficiency get immediately addressed, because that child is shown to be at increased risk for lead exposure if they are iron deficient. So, be vigilant about the lead dangers. Understand that lead continues to be an ongoing environmental source of toxicity for our Michigan children. And also be aware that we do have resources available to you. Please feel free any time to contact Michigan's Childhood Lead Poisoning Prevention Program. The phone numbers can be seen here, 517-335-8885, or toll free at 888-322-4453. The website, www.michigan.gov/lead. We hope that this has been helpful to you. Thank you.